CNBC's pharma reporter Meg Tirrell is with us tonight with Dr. John Hackett. He is the VP of Infectious Disease Diagnostics at Abbott Labs. Meg?
You know, a lot of questions from the last week when we saw a study from NYU suggesting a potential high false negative rate with the ID now, and then the FDA issuing that guidance document saying also we could see the risk of false negative results and that negatives should be confirmed with another test. Just speak to kind of what you're seeing about those and whether there is a higher risk of getting a false negative with the ID now than other tests.
Hi, Meg. Thank you for taking the time to speak with me. First, I'd like to put this in perspective. ID Now is a remarkable diagnostic tool that is clearly helping to prevent and slow down the spread of this pandemic. It is very effective. To put it in perspective, there's been 1.5 million of these tests run, and 15 false negatives have been reported to either Abbott and the FDA. So the NYU study is an absolute outlier, fundamentally different than data that's been generated in any other studies related to the ID Now platform, and vastly different than what our customers' feedback is on the performance of the test. But we have large customers such as CVS that are seeing positive rates at or slightly above the local infection rate. So the test is definitely performing in a very solid manner.
Well, still, the FDA issued that guidance last week about the ID Now test, saying there is that risk of false negatives. To what do you attribute the FDA's action there?
So this is prudent, and we've been working with the FDA actually even before launch of the ID Now platform very closely. And their guidance of recommending from a medical perspective that if you have an individual who has symptoms of COVID, the signs and symptoms, that if the test is negative, that it should be tested with an alternative platform. Again, that's prudent. You really need to take the clinical picture in combination with the diagnostics. And that would hold true for other types of testing and other diseases as well.
Does that guidance, and Abbott saying in its statement last week too, that if a patient is given a negative result, but that doesn't match up with their symptoms, that they should be tested with another test. We know that the ID Now is used at a lot of the major testing sites, like for CVS and Walgreens for drive-through testing. But does that idea that if somebody has clinical symptoms that a doctor might be observing, does that perhaps make this test not so suitable for those settings?
It's absolutely suitable for those settings, and it's functioning well in those settings. As I said, based on the feedback we have from these sites, that they are seeing positive rates that are at or above the local infection rates. So it certainly, appears to be working as it should. I will say that there also was a study published, or a study that was discussed last week from Dr. Potu at Everett Clinic in Washington, where he looked at this test, and it had 91% sensitivity and 100% specificity. So again, coming back to the NYU study, there are some fundamental questions around this study that are very concerning. Some of my colleagues called the researchers at NYU to discuss the study. And, it raised a number of concerns. First, in terms of the patient population that was monitored using it. And questions that really weren't answered in terms of how long from the onset of symptoms to the point where the individual was sampled and then being tested. And, a lot of these questions weren't answered. They acknowledged that there were that there were limitations to their study, that it wasn't a controlled clinical study. And I will say, when you look carefully at the data, what's interesting is that the proportion of what they purport their comparator test was, over 1,400 patients had CT values that were 38 or greater, meaning extremely low levels of virus. And yet the 31 specimens on the dry swabs that they looked at with ID Now, 45% of those were in that 38 CT or more level. How do you explain that? This is really concerning in terms of the population. It certainly doesn't appear to reflect their population based on their own numbers in their study. So definitely some concerns around how this study was done.
Certainly, and we appreciate you joining us tonight to discuss it, and we hope you'll come back and talk with us more about testing in general, which is so important. Thanks for being here. Scott, back to you.
Absolutely. Thank you.
All right, Meg, we appreciate it. Dr. Hackett, our thanks to you as well. Let's bring back in Dr. Gottlieb once more. Dr. Gottlieb, how should we feel about this Abbott ID Now test? Do you have confidence in it tonight?
I do. This is a very good platform, but like a lot of other testing platforms, we need to make sure that it's used appropriately. This is a platform that's best suited for the clinical setting in a doctor's office where patients might be presenting with symptoms of coronavirus, and the doctor uses this to get a very quick result. But if the test shows a negative result and the doctor still has an index of suspicion that the patient might have coronavirus, in that setting, they're going to send off a confirmatory test. They're going to send off an overnight test, a PCR-based test, just to make sure that it's not a false negative. We use this test for flu in this way. We use it for strep throat. So it's a very good point-of-care test in the hands of a provider who might have an index of suspicion and send off a confirmatory test. What it's not good for is using as a screening tool for an asymptomatic population, because there is a rate of false negative results here where patients might have COVID. They might just be asymptomatic, and you might get a negative result with this test. But in an asymptomatic population, in a general screening tool, if that person has a negative result, you're not going to test them again. And so that every platform needs to be used appropriately, and in the hands of a provider used appropriately, this is a very good platform.
Dr. Hackett, though, was suggesting that it was okay to use this test in a CVS-like or likewise setting. It sounds like you would disagree with that you wouldn't advise consumers necessarily to go to a drugstore and have this test done?
Not necessarily. I think the people who should be getting tested with this platform are people who are presenting with symptoms or might have been exposed to the virus, where there's an index of suspicion that they might have coronavirus. And therefore, if you get a negative result, you might follow up the test with a confirmatory test, depending on what the clinical circumstances are. What I wouldn't use this test for is just screening a random population of healthy people to see if coronavirus is silently spreading in the population and there's some asymptomatic people. So frankly, I wouldn't use this as a screening tool for people who are just presenting, for example, for a meeting and trying to see if someone could be positive but not have any symptoms. For that, you want a test that's more sensitive. And the Cepheid Gene Expert is a point-of-care diagnostic. It takes a little longer to run that test, but it's a more sensitive test, and that's probably better suited for screening asymptomatic people who wouldn't be getting screened otherwise, but for the circumstances that you want to rule them out for having coronavirus, for, admitting them into some complex like the White House, or, as a return to work tool or something like that.
We've discussed vaccines tonight and the race for one. We've now discussed testing. Where do we stand, though, on therapeutics? What's the latest?
Still making progress. I mean, remdesivir, we've talked about many times. I think the antibody drugs that are being worked on by 4 biotechnologies, and now there's a 5th entrant, but they're much further behind, Sorrento. But the 4 companies, Vir Biotechnology, Lilly, Amgen, and Regeneron, are continuing to make progress. They say they'll be in the clinic this summer, and I believe one or more of those drugs could be available at some point this fall. Probably not early fall, but at some point this fall, we could have one of those therapeutic antibodies available. And that could be used both as a prophylaxis to prevent infection, as well as a treatment in early infection. And I think the combination of one or more of those antibody drugs with remdesivir does give us a good combination.